let me know when to switch over.
Yeah, next slide, please. Only one slide?
Can you see this? The next slide is put up.
Yes, yes. Okay. Okay. Okay.
Yeah,
Any more
let your
slides, Dr.? Okay.
no. A few
Okay,
seconds
okay.
left.
First slide, please.
Yeah. Sure. Give me a moment. Yeah, you can start.
Hello, I am Susan ST5, and you are?
Hi, I'm Ankita. I'm ST1.
Nice to meet you, Angita. How is the department?
It's good. I'm learning so many new things.
Okay. Okay, good to hear about that. Everyone is cooperative?
Yes, very much.
Oh, okay. So, any particular reason, Ankita, you want to learn more about the CTG?
Well, I was posted on the labor ward yesterday, and I witnessed a patient being monitored on CTG. So I was interested in knowing about CTG.
Sure. Ankita, we'll together see what are the implications of CTG, and I can see that you want to learn the components and how to interpret and how to manage according to the CTG. Okay, so together we will see, and at the end I can provide you with some information material on strategy. Okay, and
Okay.
any point, Ankita, if you feel you are not clear, then you can surely tell me. Okay.
All right. Fine.
So you have seen managing patients based on CTG as well as a patient as a whole. Am I right?
Yes, I've seen.
Oh, okay, good. And so coming to the CTG, this is very important for the patient in labor as well as any antenatal patients, and coming to the how to interpret the CTG. So it is based on one mnemonic that is known as Dr. C. Bravado. So I will tell you the components. C means contractions, and B means baseline rate. Okay, and A
Yes.
acceleration, and variability. Okay,
Okay.
and first and foremost is we have to define the risk in any
All
case.
right.
That is, for example, in our case, this patient she came with a leaking. She is 40 weeks pregnancy. Came with
Yes.
leaking. Okay.
Yeah. Right.
And Angita, we should not treat the patient actually. Sorry, we should not treat CTG. Actually, the patient as a whole we have to consider. Okay, patient's clinical picture and along with the CTG interpretation. Am I clear?
Yes. Okay. Yes,
So
you are.
coming to this one, so baseline, coming to the contractions, we can see the down, you can see first is the heart rate. First upper hand it is showing, and the second, the down, it is showing the contractions. For example, in the 1, 2, 3, we can see roughly 3 contractions almost. Okay, That one, that upstroke, that
Okay.
is the contractions. And
Yeah.
baseline heart rate, regarding the baseline heart rate, in the upper hand, that is the heart rate tracing. It is showing the baseline rate as around 150, we can say. Okay. So coming to the normal
Okay.
is up to 110 to 160. Okay. Recent one.
All right.
Okay. And that is the baseline heart rate. And also we have to see that small variability is there. That is the variability pattern. You can see the small
Okay.
wavy picture. Can you see? That is the variability.
Yes.
And normal variability, it should be between 5 and 25, less than 5
Okay.
and more than 25. That is significant.
Okay.
What is
All
the
right.
normal
Okay.
baseline heart rate, Ankita, in this one? Can you tell me?
A normal baseline rate is 110 to 160. In this one, I think
Sorry.
it is around 150.
Okay.
Okay.
Hello.
Yes, I can hear you. Hello?
Okay. And there are coming to the decelerations. So you can see the
Mm-hmm.
heart rate is going up to 120. Okay.
Yes.
There are
Mm-hmm.
three types of deceleration mainly. One is the early deceleration, second one is variable deceleration, third one is late deceleration. Coming to the early
Yes.
decelerations, it may be due to head compression, especially when the baby comes down during active labor. It can be early deceleration, which is not very significant. So coming to this picture, when we will
Mm-hmm.
correlate, down, I told you the second tracing is regarding the contractions. So early deceleration means it is almost like mirror image. You can see this tracing almost corresponding to the uh, contractions. That is known as early deceleration. And second one also, you can see this is the contractions, and more or less it is corresponding. So it is known as early deceleration. Are you
Okay.
with
So
me?
these are early deceleration.
Early deceleration.
Okay.
And it is not of much significant. It can be there, uh, okay, due to head compression usually. And second one is variable deceleration, which has no relation with the contractions, and it can be due to cord compression. So in that case, we have to do simple measures like conservative measures. If there is hypotension or anything, have to give fluids, change the position and all. That is regarding the variable deceleration.
All right.
And late deceleration, this is the contraction. When the contraction finishes, and then you can see the deceleration. But in here, actually, it is only up to 120. So it is not very significant. Okay. Just to
Okay.
make
Okay.
you
Yes.
um,
So it is
clear.
not a deceleration
Next,
since it is still
it is
120.
when coming to the, yeah, it is up to 120. That is acceptable only. Okay. Hello.
Okay. Yeah.
And then third one is late deceleration. When the contraction passes off, in that case, you can see the deceleration, it is going down, and sometimes even up to 90, and even rarely you can see in the labor room when we are seeing the patients, suddenly it is drop, it can be going up to 60 and all. In that case also, we have to say, as I already told you, it should be the whole clinical picture. We cannot treat the patient as a whole. Suppose, for example, if the patient has any meconium or any high risk factors, like patient already it is IUGR, so like that we have to correlate. Okay.
All right. All right. Okay. Got it. Got it.
There.
Doctor, actually, this patient had meconium and she was
Mm-hmm.
4 centimeter dilated. And that's when they
Mm-hmm.
started the CTG. So, what is the correlation?
Yeah. For example, already meconium, regarding the meconium also, we have to see whether it is significant meconium that clinically we can make out. Sometimes it may be in the our patient already 4 centimeter. And if it is thin meconium, it may not be significant. It may
Oh,
be,
okay.
it may not be significant. Significant means
No,
meconium with
it was thick
yeah,
meconium.
thick meconium. Okay, okay. Thick meconium. What
Yes.
was the CTG that time? You remember?
This was the tracing.
Okay, this one. Okay, okay, okay. So with the significant meconium, then in that case, it is not of significant. Defined risk means if the patient is having any other underlying comorbidities like raised BP with, IUGR in that case, and meconium, it is significant meconium, that is the defined risk. So in our particular case, it is not significant. So what we can do, we can put the patient on conservative measures and continue monitor, and we can manage the patient. Okay, because patient
Okay.
along with the CTG as a whole clinical picture we are seeing. And but at any
Okay.
particular time, suppose that it comes down to 90 and it is persistent, okay, along with the late
Hmm. Hmm.
deceleration, that means chronic
Hmm.
uteroplacental insufficiency. Okay.
Okay.
Hello.
Okay. Yeah, yeah, got it. Okay, your time is up.
Hello. Hello. Sorry,
All right.
Ankita.
What? Sorry for what?
We send. Okay, okay.
Sorry?
Hello.
Okay. Yeah, so what do you have to say? What is your reflection on the task?
So I was very slow and didn't ask her questions in between. I should have asked one or two questions, and I was only giving like lecture, I think.
Okay, fine. All right.
Mm,
No problem. But see, the dictum in
mm,
part 3 exam is that you need to read the question carefully. You need to know what domains are being assessed. Okay.
mm.
And basically, you need to understand the situation that is uh,
Yes,
in question. So here
yes,
it is told to you that you are seeing your ST1 who was posted on the labor ward, and
yes, yes.
she's seen some patient the previous day. Some details of
Mm-hmm.
the patient are given to you, and if
Mm,
you notice,
mm,
the domains are saying information gathering, communication with colleague, patient safety, applied clinical knowledge. So there is
mm.
information gathering, right? Okay. What is the task saying? Task is saying explain the components of CTG and interpretation, which you did partly,
Mm,
and
mm.
explain management of the patient, right?
Yes. Mm,
So you need to understand that a patient is involved here. And I tried giving you clues and I said that,
yes.
okay, the patient had meconium, right? So
Mm,
that means that is a clue you need to take. And then at least then you should realize that maybe there is more to the station. Okay, so
yes.
she's telling you that there is meconium. You should
Mm,
ask
mm.
questions regarding the patient situation that would help you interpret the
Yes.
CTG, because as you repeatedly said, and it is repeatedly said in the NICE guidelines as well, that you do not treat the CTG alone. You look at the whole patient situation, and this is said repeatedly. And it is very important to first assess the situation of the patient. Okay, that is why
Mm,
we have the mnemonic Dr. C. Bravado starts with determined risk. So this determined risk bit was not done, right?
mm.
So you
Yes.
realize where was the mistake?
Mm,
All right.
yes.
Okay. So how do you determine risk? There are certain questions, or there is certain history that you would need to ask from the role player. Okay. What would that history be? You need to know findings at admission, dilatation, leaking is already provided to you. What was the color of the liquor? Bleeding, fever, blood pressure, fetal size, so there is a growth restriction or not. Okay, how did she progress? Okay, or why was the CTG started in the first place? Do you start CTG for all patients? No. Okay, so why was the CTG started in the first place? So how was the progress? What time did she deliver, if she delivered? Did she have any obstetric complications like preeclampsia, diabetes, anything? That is important to know because that may be the indication for the CTG. What was her parity? Okay. What were the antenatal investigations, the antenatal course, whether she had any medical diseases. These are the history points that you ask in any laboring patient. So medical diseases, surgeries, allergies, these are safety points. Okay. Addictions is not really required, but if there is chronic smoker, then you would want to monitor her on a CTG. Then support in labor, BMI. BMI is another risk factor. So any identified risk factor that is necessitating the CTG monitoring, you would need to identify in this station because there is a patient involved. It is not just simple CTG teaching station. There is patient management as the task. So you need to know details of the patient, right? So you need to ask this background information, okay? Whether it is patient choice for intrapartum monitoring, okay? Because now the NICE guidelines mentions that the choice is to be given to the patient. If the patient, even if the patient is low risk, but she chooses CTG monitoring as a way of monitoring her baby intrapartum, then you have to respect her wishes and allow her to have a CTG monitoring, right? So this is the information gathering that you need to do in this station. All right. So since this bit of information gathering was not done, I cannot give you any score for information gathering. So you would get a 0 on information gathering. So now you understand how you can easily lose marks, right?
Yes.
If you do not understand the station. So which is why in the 2 minutes time, reread the station. That's important. All right. So and other things that you did, like the teaching template, was okay. You asked me how I'm doing in the department, and you can always say things like, if you need any help at any point of time, I'm always available for you. And you can say that I would give you reading resources, etc., etc. Ask her to repeat, check understanding. All these are basics of teaching. But one important thing that you need to understand here is what exactly about CTG she wants to know. So, what are the components that are being assessed in the station? Because see, you can talk on CTG even for an hour. Okay. You have only 10 minutes in the station, right? So you need to know what exactly you need to touch upon. What aspects of CTG monitoring you need to discuss in the station. So which is why you don't make your agenda there. Okay, like you said, I would tell you about the components of CTG. No, you ask the role player. What is it about CTG that you want to know? Right? So that's important. Understanding what the station is assessing you for, right? Then, okay, so now we'll move on to reading a CTG. Okay. And here I will tell you the points that are important for you to say in a station for part 3 exam. At the same time, I will tell you how how to read a CTG, right? So okay, so there are certain general principles of CTG monitoring which you need to keep in mind, which are stated in the NICE guidelines. Like, you need to discuss the fetal monitoring options with the mother or the birthing companion. This is new, okay, revised in 2022, because earlier it mentioned that high risk patients to be offered CTG monitoring. Now they say that you need to offer them the option of CTG monitoring if they are willing for CTG monitoring. You respect the wishes, okay? Early assessment. This is another important thing, that a patient on CTG has to be assessed early, okay, if she has risk factors. Then you document the assessment early. Again, important to note, okay? And these points are important to mention before you go on to interpretation of CTG. All right? Discuss with the woman about the early assessment. So it basically, the new NICE guidelines is involving the woman, the patient, in her care. Okay? Yeah. Provide one-to-one support. Okay? Explain to the woman the antepartum risk factors and CTG are used to evaluate the baby's condition in labor, and CTG monitors the contractions, fetal heart, and may restrict mobility. So these are the points that you need to, for example, if you have a station where a lady is coming to you and she's asking you about CTG monitoring, these are the points that you would need to tell her. You would need to tell her that we do not just treat the CTG, we would take the overall picture into account. We would take the risk factors as well as the CTG findings into account before interpreting the risk of the baby or the fetal status rather. So CTG monitors the contractions, the fetal heart, and may restrict mobility. So explain that decision making in labor, that is decision making regarding intervention in labor, whether you're going to deliver her, not deliver her, continue monitoring, takes into account the overall picture and not just the CTG tracing. Okay. Normal CTG is reassuring. However, when the CTG is abnormal, there is less certainty about the baby's condition. Okay, so these are the points that you need to keep in mind. Okay, and CTG monitoring for everyone may increase the risk of intervention in labor, which is why it is recommended for high risk patients. All right, so these are the principles of CTG monitoring which you need to keep in mind. And if it is a teaching station, you can briefly talk about these principles, but you have to mention about early monitoring, you have to mention about the choice given to the mother, the risk factors, basically the indications of the CTG, which are stated in the NICE guidelines. We won't go into the depth of that. And the early assessment, one-to-one support, and that CTG is used to monitor the contractions and fetal heart rate, and overall picture is to be taken into account. And CTG monitoring for everyone, for all patients, may increase the risk of intervention. So these are the points that you need to keep in mind while you are talking to your colleague for the teaching task. Then at each assessment, what are the things that you would see? Maternal risk factors and any evidence of fetal compromise, fetal antenatal risk factors for fetal compromise, new or developing intrapartum risk factors, progress in labor, including the characteristics of contractions, and fetal heart rate monitoring. Okay, and obtain an in-person review of early assessment by another clinician. That is, this is what is mentioned in the NICE guidelines, that you involve another clinician for the review of CTG. Now, all these points you will not have time to say in the station. Okay, this is for your knowledge, but I would highlight the general principles that are mentioned here, and you need to briefly say those when you're doing the teaching station. Okay, and document. Okay, so there were some questions about the speed of CTG, etc., etc. Yes, the CTG that was shown was 3 centimeter per minute, and usually the CTG that are given to you are 1 centimeter per minute. But then, because it would be too small, I did not. I mean, it would be difficult to see in an online scenario. That is why I took 3 centimeter per minute. Anyway, so what are the components of CTG that you would take into account? Now, this is what is important. Okay, the interpretation part. Okay, so listen carefully. Okay, so we have contractions, as you mentioned rightly, contractions, baseline fetal heart rate, variability, presence or absence of decelerations, and presence of accelerations. This is what we need to understand. So now the first part, contractions. Okay, so here, as you rightly mentioned, how this is a trace. If you can see this, let me use a tool to point out. Okay, right, 1 minute. Okay, right. Okay, so if you can see my cursor, so this is 3 centimeter per minute, as we said. So this is 3 centimeters. Okay, from this first line to this line. So this is 1 minute, second minute, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th. So this CTG tracing is over 10 minutes, okay, which is not sufficient for you to interpret the CTG. You would obviously need at least a 30 minutes tracing for a CTG, good CTG interpretation. But this CTG tracing shows you the components of CTG. So in the 10-minute time period, how many contractions can you see here? That is what you need to check. Okay, you can see around 3 contractions. Yeah. So that is what you need to check when you check contractions. So if it is 1 centimeter per minute, then each small square will correspond to 10 minutes, right? So then you have to see in that those small squares, in 10 such squares, how many times there are contractions. And then that will give you the contraction rate. Okay. So there are 3 contractions in 10 minutes in this particular CTG tracing. Okay, so the next thing that we want to know is the baseline fetal heart rate. As you rightly pointed out, it is normal is 110 to 160. So in this case, what is the baseline heart rate? It's around here. This is the baseline heart rate, or it is basically the average rate. So it is around 150 beats per minute. Okay, so variability. Now, what is variability? Variability is the variability that we consider is not beat to beat variability. That's a typical confusion about CTG interpretation. It is the long-term variability. By long-term variability, I mean that these, I'm not sure if you can see my, okay. So this is long-term variability. While beat-to-beat variability are the small oscillations that happen in the waveline, in the baseline. Okay, this long-term oscillations that happen is, you can't see the cursor. Can you see the cursor, the red one?
No, ma'am. You can see it as a cursor now.
You can see it?
Yes, ma'am.
Okay, okay, fine. All right. So what I am trying to say is that it is this particular oscillation, these oscillations in the baseline that you would check when you are looking at baseline variability. All right. So here, I'll show you the variability. This to this. Can you see that? So this is the baseline variability, which is coming approximately to 20 beats per minute. All right. So decelerations. Now decelerations is something that you need to, that people usually get confused about. Okay. So as you mentioned, you said that these are early decelerations. So Dr. Susan, can you just go through the CTG once again and just tell me if it is actually early deceleration or it is something else? So is there anybody else who has a different opinion?
Ma'am,
Hello? Yeah.
it looks like a variable deceleration, ma'am.
Mm. Yes, yes. You're right. You're right. It is variable deceleration. As you can see here, in this first deceleration, it is not an exact mirror image of this deceleration. This deceleration peaks on the second line, while this deceleration is dipping down before this deceleration. I mean, before the contraction, right? It is not an exact mirror image, and there is shouldering as well. Again, here, it is coming a little after or maybe with the deceleration. Okay, so what is important for you to note is that it is not enough to just look at one particular deceleration to know whether it is early deceleration or variable deceleration. You have to look at the entire CTG tracing and the pattern. If there is a uniform pattern that is followed by the decelerations with respect to the contractions. So just based on one particular deceleration, you cannot say whether it is variable deceleration or early deceleration, because in this second one, it looks almost like an early deceleration. But we call this variable deceleration because the pattern is not followed uniformly through the tracing. Like here, it is coming before, and here it is almost with the contraction. So there is no definite uniform pattern which is followed, which is why it is important to look at the entire CTG tracing. Okay. So, and you cannot say, oh, the first one is variable deceleration, the second one is early deceleration. It's not, unlikely. Okay. So when you look at deceleration, what are the things that you need to observe? So first is type of deceleration. So here it is variable deceleration. Okay, there are many points. Remember all those points when you're interpreting the CTG. Okay, duration of each deceleration. So can you tell me, can anybody tell me what is the duration of each deceleration here? You can message also. Or
Ma'am, looks
over
like
how
around 30
much time is the
seconds.
deceleration?
30 to 40 seconds.
Okay, it may not be 30 to 40 seconds because remember, now you have to understand the speed of this. Now you see the
Yes, ma'am.
cursor? You can see the cursor, right? So
Yes, ma'am.
this is 1 minute. Okay, so you can say that this deceleration is lasting for almost 1/3 the 1 minute time. So it may be 1/3 would be 20. So around 20, but it is going a little beyond that. So 20 to 30
30.
seconds.
Okay.
So it depends. Now you know why the speed of CTG tracing is important. Okay, for you to know exactly the squares correspond to how much time. All right. Now,
Hello.
next.
Hello.
Yes, Dr. Aparna.
Uh,
Yeah.
yes, ma'am, for 1 centimeter per minute, I know that the small square is 30 and two small squares are 1 minute. But can you please explain in this CTG the how much like what corresponds to the small square, and then like I'm confused with how do we calculate in this one?
See, you can see my cursor, right? It's important that you see it.
Yes.
Can you see it? Yeah.
Yes.
So
Yes, I can.
now you can see this is the point. Okay. So,
Yes.
yeah. So this will be 1 centimeter, right?
Okay.
Okay. This will be the second one. So second 2 centimeter, right?
Okay. Okay.
And this will be third.
Okay.
So 3 centimeter. So you can say the distance from this line here to this line is 3 centimeter. I mean, sorry, is 1 minute. Yeah, 3 centimeter is 1 minute.
Okay. Okay.
Okay. So
Okay.
if this is 1 minute, then this deceleration is over 1/3 the minute, isn't it? This is
Yes.
C. This is the dark line here is to this dark line is 1 minute.
Okay.
Okay.
Yes.
So
Yes. Okay.
this one square, this second square, this third square. One square is 1/3 the minute. What is 1/3 the minute? 20 seconds. So this deceleration is approximately 20 to 30 seconds. Okay, I'm saying 20 to 30 seconds because it's going a little beyond this. Correct?
Okay. 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 Got it. Okay.
Yeah, yeah, yeah. So then, so that is the second point, that the duration of CTG. The third point is duration over which the decelerations exist. That means the time period over which the decelerations exist. Okay. So it would be, in this case, as I mentioned earlier, it was 10 minutes that we counted. Okay. Here it is, I think the 8-minute part is only shown, but we counted earlier in that CTG, it was a 10-minute duration of CTG, considering that it is 3 centimeter per minute and not 1 centimeter per minute. Okay, that is clear to you? Hello?
Yeah. Yes, ma'am.
Yes, ma'am.
Okay, okay, fine. Then you need to check if the deceleration that is happening is coming back to baseline and the baseline is continuing. Is it happening here?
Yes.
Yes, it is happening. Okay, yeah. The next thing that you need to check is whether there is shouldering. Okay, so shouldering is basically happens usually in variable decelerations. When there is a deceleration, it comes back and it shoots up. Okay, so is it happening here?
Yes.
Which is a reassuring sign. It means that there is initially venous compression then there is arterial compression, okay, and then while the contraction is passing away, the veins remain compressed. Okay, so more easily as compared to the artery, which is why you have the increase in the decrease in the preload, and that results in increased adrenaline and tachycardia in the fetus. So that is the shouldering. Okay, so that means the fetus is able to respond to the compression. So it is a reassuring sign. So yes. So then you have to check if there is a variability, if the variability in the deceleration is good. So that means the deceleration, if there are these wavy lines in the deceleration, it is a good sign. Okay, rather than a deceleration being a smooth deceleration. Okay, so that is the other thing that you need to check. The next thing which is important in interpreting CTG and to classify the CTG as amber and red, etc., is whether the decelerations are associated with 50% of the contractions or not. Now here you would say that yes, they are associated with 2 out of 3 contractions, but this CTG tracing is only of 10 minutes duration. You have to look at a longer tracing. You have to have at least a 30 minutes CTG tracing, okay, which you may get in the exam. Okay, in the exam you may get a long trace. It is not possible to show it online, but you may get a long trace, particularly in the on-site exam. Okay, so whether it is associated with 50%, here I would say that considering that this pattern repeats, I would say yes. Okay, if the decelerations are variable, which is something that you would more commonly have, variable decelerations, you have to check if it is lasting for more than 60 seconds, reduced variability in the deceleration, like this in the deceleration, whether the variability is reduced, failure or slow return to baseline fetal heart rate. So you would have a pattern where it is going down, coming up, and then going very slowly back to the baseline, or it is not going back to the baseline at all. And loss of previously present shouldering. So these 4 characteristics of variable deceleration are the concerning characteristics of variable deceleration. So when there is variable deceleration, you have to check whether these concerning characteristics are present or not. Now, can you tell me if any of these concerning characteristics are present in the variable decelerations that we have seen here?
No.
No.
No. So they are good variable decelerations, I must say. Okay. So now let's see. What is this type of deceleration? What type of deceleration?
Early?
Early.
Early?
Okay. Any other answer?
Early with loss of variability.
Now tell me, what is it?
Variable?
Variable.
With
Variable.
presence of
Yes,
shouldering and
exactly.
variability.
Yes, exactly. So
Right.
this is the typical mistake I had mentioned earlier. If you remember, don't just look at one particular deceleration and be in a hurry to classify it as variable or early deceleration. It may look like early deceleration with one particular segment, but if you look at the deceleration pattern, whether it is being followed uniformly with respect to the contraction, it will not be so in case of variable deceleration. So you have to look at the entire CTG tracing. Clear? Because when I had shown you without this second segment, it did look like early deceleration. Now when you see this, there is no definite pattern between followed by the decelerations with respect to upstroke, that is the contraction. So it is a variable deceleration pattern. And if you are confused in the exam, please remember variable decelerations are much more common than early decelerations. Okay, so I mean, it may not be so in the exam, but this is something that you need to remember, and most of the stations will have variable decelerations. Okay, what is this?
Early.
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 Yes, yes. This is early deceleration because as you can see, there is uniform pattern which is being followed by each deceleration with respect to the contractions. Early deceleration. So then, what is this? Already marked there.
Late.
Late.
Yes,
Late
this is
deceleration.
late deceleration because another important thing, if you notice here, this is a really a pathological CTG because there is a late deceleration going down. It is coming up and it's not reaching the baseline even. Okay, so here also, if you can see, you will have a typical picture of such decelerations in late decelerations. You will have a little bit of tilt to one side and is coming back and not reaching back to the baseline, which is quite pathological. Okay, so late decelerations are because of placental insufficiency and that is pathological. Okay, yeah. This is what is the interpretation of CTG. Okay, so this I think most of you would know. Okay, as far as the contractions are concerned, it is classified as white and amber. There is no red for contraction. So less than 5 is white, 5 and more is bad. So you have to aim at 3 to 4 contractions for a good uterine activity. 5 and more is not good. Okay, the baseline rate 110 to 160 is a stable rate. Okay, and I mean stable baseline rate is a normal baseline rate. 110 to 160, it is white, we all know this. Variability 5 to 25 is white, we all know this. While amber is when the baseline rate increases more than 20 beats per minute. Okay, by more than 20 beats per minute. That means the fetus is trying to cope with the stress, so trying to increase its heart rate. It's trying to cope with hypoxia. So if there is a rise, gradual rise or a rise in the baseline rate that you notice by more than 20 minutes, it is 20 beats per minute, it is amber. Okay. 100 to 109 beats a minute is also amber. But what they say is you can continue the usual care if this has been stable throughout labor and there is normal variability and no variable or late deceleration. So even if it is between 100 to 109, you may get a CTG like that. And what would you do in this particular case? That may be the question. So even if it is between 100 and 109, if there is normal variability and there are no decelerations, you can continue care. Okay, the labor care. When you can continue the CTG. Okay, and another ember is when you are unable to determine the baseline. Okay, so for red, for baseline rate is obviously anything less than 100 or anything more than 160, fetal tachycardia or fetal bradycardia. Okay. Um, hello, can you hear me?
Yes, ma'am.
Okay, okay, because I just got a message saying no audio. All right. So that is about the baseline rate. Now variability, 5 to 25 is normal. Fewer than 5 beats a minute for between 30 to 50 minutes is amber. More than 25 beats a minute for up to 10 minutes is again amber. While in for red, it would be fewer than 5 minutes for more than 50 minutes, and 5 beats for more than 50 minutes, and more than 25 for more than 10 minutes. So remember 10, 50, and 30, these figures. Okay, so this would be about, see, you don't really have to go into the depth of this. If you see a patient on CTG with reduced variability, you have risk factors there, you say you want to deliver, that's fine. Okay, so reduced variability is more indicative of fetal compromise. That's something that you need to remember. Okay, now, decelerations. Why it would be no decelerations or early decelerations or variable decelerations without concerning characteristics. Okay, so variable decelerations is also considered white if there are no concerning characteristics. This is something that you need to remember. But there is a but here, that if the patient is having risk factors, like in this case there was meconium or bleeding, etc., you would need to do something or you would need to take that CTG seriously. Okay, or you may have to consider intervention. Okay, so that is what you can, like for example, just to give you an example, if the patient is having significant meconium and there are variable decelerations throughout the trace without concerning characteristics, but the patient is early in labor. I mean, she's not in active labor yet. There is already meconium. It is not wrong if you say, I would like to deliver the patient by cesarean section. Okay. The reason I'm telling you this is that there are significant risk factors for fetal compromise. Okay. For that matter, a better example would be if the patient is bleeding, okay, and there are variable decelerations, patient is far from delivery, okay, in early labor, again, you would consider delivery because you would be concerned about the baby, right? So that is what you need to remember. So most important factor here of the interpretation is the DR, Dr. C. Bravado, DR, determine risk, okay? So EMBER here is what? Basically repetitive variable decelerations with any concerning characteristics for less than 30 minutes. So repetitive variable decelerations is when they are present with more than 50% of the contractions. So that is repetitive. Okay. They should be having concerning characteristics. So now you understood why interpreting a deceleration with all those factors that I listed there in the previous slides is important, because you have to first understand what type of deceleration, if they are repetitive, they are not repetitive, and if they are variable, if there is concerning characteristics or not. Okay. So repetitive variable deceleration with any concerning characteristics for less than 30 minutes. But remember, EMBER is not just variable deceleration, so it is repetitive variable deceleration. I mean, it is variable deceleration with concerning characteristics. So our CTG trace there will still be classified in under white, because the variable decelerations that you saw there, the two decelerations that you saw, did not have any concerning characteristics. Okay, so that is still white. Now, if there is variable deceleration with any concerning characteristics for more than 30 minutes, that is EMBER. Repetitive late decelerations for less than 30 minutes is again EMBER. Okay, what is red? If it is repetitive variable deceleration, sorry, repetitive variable deceleration with any concerning characteristics for more than 30 minutes, repetitive late decelerations for more than 30 minutes, and can you mute yourself? I think it is Sarah, Dr. Sarah. Hello. Hello, Dr. Sarah, can you mute yourself? Yeah, okay, thank you. Yeah, so if there are repetitive late decelerations for more than 30 minutes and acute bradycardia or a single prolonged deceleration lasting 3 minutes or more is a red sign. Okay, so right. So then going to the next one, which is interpretation. So how do you interpret? When it's normal, if there is no EMBER, no red feature. Suspicious if there is one feature which is EMBER. Okay. Pathological if two or more features are EMBER or any one feature is red. Okay. What is good here is that this red, white, EMBER is a little easier than the previous classification. Okay, it is a little better than the previous classification, at least to remember. Okay, so our CTG that we saw, less than 5 contractions, so it's white. Baseline rate is 150, again white. Variability is 10 or 20 beats that we saw, so that is also white. Then decelerations is it is associated with 50% of the contractions, but there are no concerning characteristics and the trace is just over 10 minutes. So it is not enough to really interpret the CTG well. But if it continues this way, you can still say it is white because there are no concerning characteristics. So you remember that you need to understand what concerning characteristics is in case of CTG. Okay. So in case of variable decelerations. So this CTG would be classified as normal. However, in view of the meconium, you need to monitor the CTG and to consider the overall picture, the dilatation, the progress, and see if the patient would deliver soon or you need to intervene. Okay, like if the patient is having meconium and the patient is not dilating favorably, then you need to take action. All right. So yeah, now you will have in the labor ward prioritization stations, you will have CTG. You may not have CTG for interpretation because that may be difficult, but sometimes you may have in the on-site exam CTG for interpretation. They may just give you that the CTG is pathological or CTG is suspicious. What would you do? Right? So this is a typical question in almost every labor ward prioritization station. So first remember, whenever that question is put, think of the risk factors that are associated. Okay, what are the risk factors in the patient? Like patient is not progressing, patient is obese, patient is diabetes. So these risk factors you have to consider. Okay, then if the interpretation is given to you as normal, if it is given, then you have to just continue with the early documentation that is mentioned in the new guideline. If it is suspicious, then what do you do? If it is suspicious, then and there are no other risk factors, then what you do? If there are no risk factors, you would just do the conservative steps. So what are those conservative steps? Basically, you would perform a full risk assessment. So check if there is anything that has come up. Okay, any risk factor that has come up. Include a full set of maternal observations, take into account the whole clinical picture and document the findings. Note if there are any accelerations, because if there are accelerations, fetal acidosis is unlikely. Okay. If the CTG was previously normal and now it is becoming suspicious, see if there is any underlying reason for this or anything that has come up, and undertake conservative measures. Basically, if there's hypotension, you treat the hypotension. If the patient changing the position may help, you do that for her. So this is what you would do if there is suspicious CTG with no other concerning risk factors. Now, if there are additional risk factors, such as slow progress, sepsis, or meconium, okay, and the CTG is suspicious, you would obtain an urgent review by an obstetrician or a senior midwife. Okay, here again, like in the previous guidelines, they mention that you would obtain an urgent review by an obstetrician or a senior midwife. So senior midwife, if she's there with you in the labor room and the consultant is busy, you are occupied with some, for example, a PPH, please do not hesitate to tell the senior midwife to look at the patient or to see the patient with suspicious or even pathological CTG. This is a typical mistake that is made in labor ward prioritization stations because we think midwives cannot be handling patients with pathological CTG, which is wrong. Okay. Senior midwife can very well assess a patient who is having a pathological or a suspicious CTG. Okay, as it is stated here in the NICE guideline. This is taken straight from the NICE guideline. So you consider for these patients fetal scar stimulation or expediting birth. Okay, if there are risk factors. So like as I mentioned, if there is meconium and you have suspicious tracing, you may still consider delivering the baby. Okay. Then this is the pathological CTG, a typical question in the exam, very common. Almost all labor ward prioritization stations would have this question. What is it? What will you do? A patient is in second stage. What are you going to do? No, one of the rooms would say that patient in second stage for 1 hour, the CTG tracing is pathological. Tell me your actions. So what are the actions? You have to say all this. Okay. So you obtain an urgent review by an obstetrician and a senior midwife. There it was obstetrician or a senior midwife. Here you obtain an urgent review by an obstetrician and a senior midwife. Okay. You exclude acute events like cord prolapse, suspected placental abruption, or uterine rupture that may need urgent intervention. You perform a full risk assessment, full set of maternal observations, same thing that you would do otherwise also. Risk assessment, very important. Okay. Take into account the whole clinical picture and document the findings. Consider the possible underlying causes that may be there and undertake conservative measures as indicated. Like you suddenly see that the patient is becoming hypotensive, and that may be the reason why the CTG is pathological. Please correct her hypotension. Please give her fluids. Please correct her dehydration. Okay. So you check for risk factors. You check for the overall clinical picture. rule out acute events that you would need to intervene in, and obtain an urgent review by a senior midwife and an obstetrician. Okay, they have mentioned obstetrician. Okay, so you can very well send a senior midwife till such a time a consultant or the ST5 is in a state to go to this particular room. Okay, if the CTG tracing remains pathological after the conservative measures, you obtain a further urgent review by an obstetrician and a senior midwife, evaluate the whole clinical picture, and if there are evolving intrapartum risk factors, you should have a low threshold for delivery. Okay, so basically the same thing. How would you say it in the exam? You just say that you would summon the midwife, senior midwife, not any midwife, senior midwife. You would till such a time that an obstetrician is free to decide and deliver, etc. So in the meantime, the senior midwife can very well go there. You need to exclude your acute events. You do a full set of maternal observations, risk assessment, and take into account the entire clinical picture and document, and talk to the woman also. It's important. If there are any possible underlying causes, you start the conservative measures. And if it persists, you would still need to have a review again and consider expediting birth. That is what you would say in the exam, because you may not have time to say everything. Okay, so you just say briefly that this is what I would do in the exam. I mean, I would do for the patient. Then, if there is acute bradycardia, obstetrician has to see. If there has been an acute event called prolapse, suspected abruption, rupture, you need to hasten the delivery. Consider possible underlying causes again and make preparation for an urgent birth, because acute bradycardia is something that is usually associated with fetal compromise, unless it is the maternal pulse that it is picking up. Okay, so that is another important point when you're interpreting a CTG for bradycardia per se. You have to look at the maternal pulse. Okay, and that is also mentioned at every point in the guidelines, that you need to check if the maternal pulse and the fetal heart rate is coinciding, because sometimes the CTG probe may pick up the maternal rate rather than the fetal heart rate. Okay, then these other points are the usual points. So okay, just to touch upon, this is the last bit. After that, what I would do is I would send on the group some more CTG tracings. You could just send a recording, or you could even type what do you think the CTG tracings are. Okay, so the other information that you should keep in mind when you are doing the CTG interpretation is basically a deceleration. This is the point that I wanted to raise with Dr. Susan, that she said that it is going only to 120. That means it is still in the normal range. That means it is not a deceleration. Wrong. Okay. So what is a deceleration? When it is going below the baseline by more than 15 beats per minute, with each episode lasting at least for 15 seconds. Okay, 15 seconds or more, right? So even if it is in the normal range, from 150 it is falling to 120, it is a deceleration. Okay, so don't get confused there, because still the deceleration is in the normal range. It may not be a deceleration. Wrong. Okay, so it is a deceleration if it is going down by more than 15 beats a minute. So an exception is when there is low variability, the deceleration may be shallow. That means the fetus is so severely compromised that even the deceleration is not deep enough. I mean, the heart rate, basically the heart is contracting at a fixed rate. Okay, so the sympathetic system of the baby is compromised. Then take into account that the longer and later the individual decelerations, the higher the risk of fetal compromise, particularly if the decelerations are accompanied by a rise in baseline, a tachycardia, or reduced or increased variability. Another important point to note here is when we see decelerations, we sometimes ignore the baseline rate. Maybe the baseline rate is at 160 or more, or say 165 is the baseline rate. Okay, and you just look at the deceleration. Yeah, variability is fine. There are decelerations, but they are also looking fine. But when there are decelerations along with a baseline tachycardia, you cannot ignore it. Okay, so when there are two such factors, you should take into account, you should consider that the baby may have some degree of fetal compromise. Okay, so okay, yeah, so start conservative measures and carry out an urgent obstetric review if there are deceleration lasting longer than 30 minutes in the presence of either a rise in baseline rate or reduced variability. This is what I just said. Okay. And take into account the risk factors, which I have also repeated here almost 4 times now. So you have to take into account the risk factors before thinking of proceeding with a cesarean section. I mean, proceeding with monitoring of the patient with CTG. You may have to consider a cesarean section or a forceps delivery, depending on the status of the stage in labor. Variable decelerations, some relevant points. If variable decelerations persist and other CTG changes are present, obtain an urgent review. So if variable decelerations, that's what I mentioned. If it is still looking normal, but there are other associated changes, you will still obtain a review from the obstetrician and senior midwife. Okay. Then, if variable decelerations with no concerning characteristics, no other CTG, including no rise in baseline fetal heart rate, be aware that these are very common, can be a normal feature in an otherwise uncomplicated labor and birth, and are usually a result of cord compression, and support the woman to change position or mobilize, because it may be because of cord compression. So they have mentioned this line here, in an otherwise uncomplicated labor. So like, that is what I mentioned in this station. In this case, she had variable decelerations with no concerning characteristics, with no other CTG changes at all. So of course it was not 30 minutes, it was just 10 minutes trace that you were given. But if it had continued for 30 minutes, in an otherwise uncomplicated labor, you would continue without much worry. But here she had meconium. So here you need to raise the question that, if not directly mention that, I mean, if you don't want to directly say that I would take for cesarean, you say that I would involve consultant because I'm worried since there is meconium. That is what you need to advise the ST1. Okay, in this case. So then, early decelerations. Take the following into account when categorizing early decelerations. They are uncommon. Okay, this is what I was mentioning, that if they give you a trace and you're confused variable or early, you can go in favor of variable because variable are more common. They are uncommon, benign, and usually associated with head compression, and they are mostly present in second stage. Okay, they are not accompanied by any other CTG changes such as reduced variability or baseline fetal heart rate when they are present usually. Accelerations, on the other hand, would be a transient increase, the same definition as deceleration, but acceleration is increase in the fetal heart rate for 15 seconds, 15 beats per minute. Okay, and take the following into account when assessing the acceleration in fetal heart rate. The presence of acceleration, fetal heart rate accelerations, even with reduced variability, is generally a sign that the baby is healthy. Remember this. Okay, so even reduced variability is considered as a ominous symptom or a sign. But if there are good accelerations, you can still consider that maybe the baby is healthy. The absence of accelerations in an otherwise normal CTG does not indicate fetal acidosis. So if there are no accelerations, it does not mean that the baby is not doing well. Okay, provided other CTG tracings are normal. Okay, so these are the some CTG tracings which I would post on the group, and you could just do a little quick interpretation. In this case, you can take the speed of CTG in both the cases as 1 centimeter per minute because it is easier to check on your devices. All right. Is that clear as far as CTG is concerned? I wouldn't want to take a lot of your time, so I thought I would just have a brief discussion on the CTG this time.
Yes, ma'am.
Okay. Any questions? I'm not able to see the, okay.
Not yet,
Any
ma'am.
questions?
Hello.
Hello? Yeah?
Hello. Ma'am, like in a teaching station, so when we are starting, so initially we also have to say there are some prerequisites like we have to check the speed of the paper, name and NHS number of the patient. All these things have to be said.
Yes, yes, yes. You have to check the speed of the paper and confirm that it belongs to that particular patient. Yes, you have to do that. See, okay, I'll just briefly tell you what all you points you have to say in this station. Okay, because I mostly told you about interpretation of CTG. Okay, so what points you have to say is that you have to first ask her the history. Okay, you have to say that, see, this is the CTG I have with me and I have confirmed this is her name, the number, and the speed of the CTG that you have said. And then you say that while interpreting CTG, you can use the mnemonic as well, Dr. C. Bravado, because that involves all these components that we have discussed. Okay, the first one is determined risk. Okay, and components of the CTG, which you would anyway discuss. Now, what's important is to talk about the general principles of CTG monitoring. Okay, these 8 points which are here, you need not say in detail about what you would do at each assessment because you will not have the time to do it. Okay, so just say the 8 points, that is the general principles of CTG monitoring in brief. Okay, you may forget some points, that's fine, but remember to say things like look at the overall clinical picture, and talk to the woman about CTG and her assessment, see if there are any ongoing risk factors, and do an Ali assessment and document. Don't forget document. That's important. Okay. So those are the points that you would say. Then you talk about the 4 components. Now, when you talk about the 4 components, you would have a CTG typically with you, given to you in the station. So you just say in that CTG, what are the things that you would see? I can see here that there are so many contractions. I can see that the baseline rate is so and so. I can see that there are variable decelerations without any concerning characteristics. Concerning characteristics include this, and it is over a period of 30 minutes. And it is associated with 50% of the contractions, because these are the things that are required for you to interpret the CTG and classify it as white, amber, and red. Okay, this is all. Okay, so this is what you would need to say in the CTG interpretation. Now, the common question that is often asked to me is whether you would say this. You would talk about the various classification. No, it's not possible because it would take a lot of your time. Okay, so what you can do instead is, see, it's important in the exam to cover points rather than elaborate on a particular point. So when in an attempt to try to cover points, what you can say is that I would give you the CTG classification. You are talking to the ST1, right? You say that I would give you the CTG classification and the assessment of components and classification into white, amber, and red. In this CTG interpretation, I can see that in this particular CTG, I can see that there are this particular component would be classified as white. Baseline rate is normal, so it is classified as white. Variability is white, and decelerations is also, there are variable deceleration without concerning characteristics, so it is white. So the CTG is interpreted as normal. Okay, so what I'm trying to tell you is, do not go in talking about how the CTG is classified and then what is normal, suspicious, pathological. You can say that normal is when there is no amber or no red, suspicious is when there is 1 amber, and pathological is 2 amber and 1 red. But if you think that you are running out of time, it is more important to end the station by giving her resources to read, by giving her the guidelines to read, etc. So if you think that you are running out of time in the exam, just make a mention that based on these red, white, and amber, the CTG is further classified as normal, suspicious, and pathological. Actions are taken accordingly. Okay, I would give you certain material to read. I would give you the guidelines, and then if you think that there is still some time remaining, quickly talk what is normal, suspicious, and pathological. That's how you do your stations in part 3, because it's important to cover points. Okay, is that clear?
Yes,
Yes,
ma'am.
ma'am.
Okay, fine. Okay, all right. Thank you for your time and patient listening. We would wind up here. All right. Happy studying, all of you.
Thank you, Mom.
Thank you, ma'am.
Thank you, ma'am.
You.
Thank you so